Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, the current president of RhAPP. Thank you for joining us for today's episode, Beyond the Joint, Uncontrolled Gout as a Systemic Disease. Gout is a condition that many of us encounter regularly in clinical practice, but it's also one that's often misunderstood. When people hear the word gout, they typically think about a painful, swollen joint or an occasional flare-up. But for many patients, especially those with uncontrolled disease, the impact extends far beyond the joint itself. Today, we're going to explore the broader story of uncontrolled gout, including how persistent inflammation and elevated uric acid levels can affect a patient's overall health, especially the many comorbidities that often accompany gout, and discuss why recognizing gout as a systemic disease is so important for improving outcomes. Joining me today is someone many of you know and respect, RhAPP board member Wendy Simmons. Wendy, it's always a pleasure to have you on the podcast.
Thanks, Amanda. I'm really grateful to be here and learn more about gout and being that systemic inflammatory disease.
Well, it's always just so lovely to have you because, again, your experience is so valued. I could ask you to talk about any condition in rheumatology and you would know about it. So I'm just so thankful to have you. Let's go ahead and just dive right in. So many clinicians and patients still think of gout as this disease of occasional flare-ups. A great toe might become swollen, red hot after perhaps, drinking beer or, having a diet that's not great. But what does it mean when we say that gout is actually a systemic inflammatory disease?
Actually, great point, Amanda. And primary care, internal medicine, probably even rheumatology in the past, gout has been referred to as that intermittent exacerbation disease process. As you've mentioned, whether it's somebody that felt that they ate shellfish, drank beer, or ate something to set this off, we're now realizing through research it is more of a systemic inflammatory disease. And what that means in rheumatology, that's part of, certainly our other disease states, that there is the process of the hyperuric acid levels and that inflammation that it is causing systemically, looking into the deposition of uric acid crystals. We're also now seeing that there's genetic predisposition. We're seeing the addition of personal metabolic chronic disease patterns that are also associated with it. So this is really leading us more into understanding that it's not just, as you've mentioned, that swollen toe, that intermittent flare. There's more to this, and I think that we'll see this as we go through our program today and look at biology and immunology.
Well, let's go right to that. Let's talk about the biology. So how does persistent hyperuricemia lead to monosodium urate crystal deposition throughout the body? And why is that important beyond the joints?
Absolutely. So when we have a state of hyperuricemia, when we find that there's this high level of uric acid, that it's actually exceeding the saturation limit of the uric acid level. Our body lacks uricase enzyme that can break down the uric acid that normally gets excreted by the kidneys to be safe. So then in turn, when you think back, if you have a real high saturation level, the kidneys can only excrete so much. What then is going to be that process? We've had that target level of 6 to 7, perhaps of a uric acid level that is have been presumed or assumed to be, that saturation level limit of the uric acid. So we have greater saturation. We have to think about what's going to happen to that high uric acid. Where's that urate going to be going? So it actually then gets out of the serum and then precipitates into the tissues. These levels of uric acid that are left in that serum really have been dissolved into molecules. This is like a nucleation type process. Then these are in a microscopic level, they bind to each other, and then they actually form those sharp crystals that we know are really causing that pain during the attack. What happens is there's like our cartilage acts as a matrix, a scaffold to really, hold these crystals. They then on their own, they bind together, they form the tophi. We have a high power microscope here in our office. So we're able to take synovial fluid out and actually prepare our slides and, look in there and be able to see those crystals. So all of this together, from the hypersaturation of the uric acid to the crystallization of that excess uric acid, then they're dissipating into peripheral tissues. Typically, these crystals are precipitating into areas of the body that are peripheral, they're avascular, they're cooler, and then this is the joint cartilage, the tendons, areas where there is less blood flow and lower temperature as well. So you can see where, through not having soluble uric acid, that leads to this smoldering process. What's going to happen now is that our innate immune system is going to recognize these deposits in these areas, that I've been speaking about. And then you're going to have macrophages come in. They're going to engulf those crystals in these areas that we've talked about. They're going to then activate something called NLRP3 inflammasome. This then, in turn, is going to stimulate a pro-inflammatory cytokine response, and those are called IL-1 beta. Here, you're going to have recruitment of some neutrophils, propensifying this, innate immune system response. And you can actually see the similarity between our other disease processes and how that mechanism of action with immunology works. So you see that process. Then you can understand now why you have those intense, painful, self-perpetuating inflammatory flares with really the immune system there as well. You have that persistent low-grade systemic inflammation that is occurring in the body. And this goes back to the first question, that we were talking about. We see now how this is truly a systemic inflammatory disease process. I know that we're going to go into some more questions, but we're going to be looking at a silent progression, right? And I think this ties into your first question, as to answering our question, even to why providers initially would treat gout as just an acute flare type situation.
That is such an amazing way to discuss it and interesting, and it really made it easy for me to understand. And I really appreciate that because, again, I think it's important that we recognize that just like we do with rheumatoid arthritis and some of our other diseases, it sounds like we really should be getting on top of these patients sooner rather than later.
Absolutely. Absolutely. This, fascinating concept with the crystal deposition occurring long before symptoms are severe. And as I mentioned, there's this what appears to be that silent phase, silent progression, and it really goes back to really what we've just learned, that you've got that blood uric acid level exceeding that saturation point, that excess uric acid crystal deposition. There's monosodium urate crystals depositing very slow, and it's subtle for the accumulation of these as well. And then that triggering of that immune response for that inflammation. It is this slow, silent progression. And as I refer to it as subtle, that there's actually what you can imagine a war or a battle going on. Another favorite word in rheumatology is smoldering. I always tell my patients, you have this underlying smoldering systemic inflammatory disease. So you think about this little war going on, and the war is between those crystal invaders and then they're invading, and then they're engaging this war with the immune system, actually, which really is a quiet process. Um, I know this isn't going to be an imaging talk, but one point I can say that if anybody has access to DECT imaging, that would be one of the things that I feel ties into this silent progression to help us earlier in rheumatology to be able to get treatment with these patients. So this leads to our uncontrolled gout.
Well, and it's so fascinating that that crystal deposition can occur long before the actual symptoms are severe. When gout remains uncontrolled, talk to me about what some of the structural and musculoskeletal consequences that can develop over time.
Absolutely. Well, based on that smoldering systemic inflammatory process, these uric acid crystals are crystallizing around the joints. As I had mentioned earlier at a microscopic level, they are binding together. Therefore, they're able to form those tophi, right? So they certainly can become visual, sometimes not so visual. They can certainly be under the skin, the joint, elbows, knees. We were always taught that little area, check around that cartilage of the ear, fingers, toes. I feel that maybe you've also seen patients in your clinic where tophi are so obvious, they're busting through the skin with that white chalky substance, right? I actually have a young man, real tall man, over 300 pounds in his 30s, and he's actually had crystals pulled out of his spine. And,
Oh,
and interestingly, somebody that you feel that has had those, all his tophi have appeared underneath the skin. You would actually think, why am I not seeing something that's breaking open or visibly white? And he's had these along the Achilles tendon, around the knees, and again, it's just the most amazing case of gout that I've really seen as well. But this actually leads then to, as we talked about, smoldering bone erosions. We can see those in x-rays, those rat bite lesion appearances through the bone. Certainly cartilage destruction, that leads to loss of range of motion, certainly of joints, joint deformities. And also this can affect tendons and cause tendon damage, weaken the tendons, cause tendonitis, and even tears. I have another patient with literal like flexion deformities, tendon deformities, uh, through this process of uncontrolled gout.
that's also, you mentioned this, and yes, this isn't a radiology talk. However, if you
Mhm.
do have access to that dual energy CT, I know we just in our institution locally were able to do this. It's so fascinating and interesting, but if you have a patient that, maybe you're just not sure, or you want to see the extent of that deposition, it's pretty remarkable when you see those CT scan images.
Absolutely, such a valuable source, and this is also that disease, as we've talked about. It's smoldering, it's systemic, it's inflammatory, and in rheumatology, we look at are there layers of different autoimmune inflammatory disease states? We know that a lot of times in certain patients, they've been diagnosed with some type of a rheumatoid arthritis or another autoimmune inflammatory disease state. So yes, that's fabulous to have that tool of imaging at your practice.
Well, and I want to kind of shift gears a little bit because, again, just like with a lot of our other diseases, right, we focus a lot on the joints, but the literature increasingly highlights this relationship between gout and cardiometabolic disease. So let's talk about that and dive into that a little bit. So, what cardiovascular conditions are more commonly seen in patients with uncontrolled gout, and what might explain that connection?
Yeah, a very important topic and correlation that we need to pay attention to as rheumatology providers as well. So, the different cardiovascular conditions that we've seen, I have seen some in my patients: myocardial infarctions, congestive heart failure, CVAs, atrial fibrillation. Those I have seen, those are really the highlights, I believe. Certainly, they're interconnected through different mechanisms as well that we need to, certainly pay attention to. There's, that systemic inflammation, those monosodium urate crystals, uh, and where they're depositing, right? Certainly, they deposit in the blood vessel walls. Some people have not realized that as well. This, again, triggers a widespread chronic inflammatory response, activates that immune pathway, accelerating the plaque buildup. A really interesting point cardiovascularly that I think that we're learning in rheumatology that many of us didn't know. Initially, I didn't realize about that accelerated plaque buildup from this response either.
What are your thoughts on the literature on the association of the timing of a cardiovascular event and gout flare incidence?
Another excellent point as well. Um, these acute gout flare exacerbations uh, can occur, weeks, months, perhaps, uh, within a cardiovascular event. It's really felt that, these gout flares, having them at that time could increase the risk of a cardiovascular event by twofold. To me, that's certainly significant. And why would that be? Because that sudden burst of those inflammatory cytokines, just think about that. Boom. That's huge. You've got this high uric acid that promotes a lot of different stress, oxidative stressors that can also impair uh, relaxation of blood vessels. Then again, you're looking at more metabolic concerns when you have that happening with that oxidative stress, metabolic syndrome, the insulin resistance, the obesity. So I've found that cardiovascular correlation very interesting as well, and really brings it to the light of us all in rheumatology as to the importance of us, treating these patients, investigating and following up as soon as we can with them.
Let's talk a little bit about kidney disease. I know I can sometimes struggle with like what's the correct medication if they have kidney disease, et cetera. But it's a very complex relationship between kidney disease and gout. Can you discuss how chronic kidney disease contributes to gout progression and also how uncontrolled gout can further impact renal health?
Yes, so that's another important organ that we need to pay attention to with gout as well, that chronic kidney disease contributing to that gout progression. This is accelerating gout because we talked earlier about the excretion of the uric acid through the kidneys. So as you have this progression, you're impairing that kidney's ability to be able to filter that uric acid, excrete that uric acid, and again, that's then again contributing to more buildup of the uric acid in the blood as well. And looking into the future impairment of the kidneys, um, the uric acid crystals can deposit in the kidney tissues. That can cause more inflammation. That can cause scarring. That also is going to then lead to more increased risk potentially of kidney stones, poor kidney function as well. I think an interesting pearl is that about 20% of the people that have gout have kidney stones. So that really speaks to, where that processing of that uric acid is with the kidneys. Also, a normal kidney is filtering about 2/3 of that uric acid from our body. So thinking about that, just putting that in perspective in your thoughts as you're thinking this through, 2/3 of the uric acid in a normal kidney. Wow, if you have some type of chronic kidney disease, that's really impressing on us that higher saturation of uric acid in the body again perpetuating that process of certainly organ damage. We've got to pay attention to that as well.
Well, and so many patients with uncontrolled gout have these other comorbidities like diabetes, obesity, hypertension, atrial fibrillation, heart failure. I mean, you kind of talked a little bit about these things already, but how should these associations influence the way rheumatology providers evaluate and manage their patients?
I think that's a very important thought for all of us. We all have unique patients. We're all in different practice settings. But there are basic things that I think we can pay attention to. I really try to bring my patients in pretty frequently, potentially back in the past before we realized all of this. We might, give them their medication to lower their uric acid and, come back in 6 months. So follow up, I think, is important until you realize you've got control, but also to be able to educate them as well, educate them about comorbidities, potentially what that uric acid and gout can do to them or other organs in their body. I think it's definitely important for us to pay attention to certainly, blood pressure, you know, identifying those patients' compliance. Are they following up with their primary care or their cardiologist or nephrology if they're at that point? Lifestyle changes, I think checking, and following up. And some patients, it is hard to do.
Definitely, but to your point, I think it's still important that we get our patients back in frequently, like you said, and not just say, "Okay, your uric acid's elevated. We're gonna get it back down," and really understanding that this is really a multi-system, process, and they also need to be seeing their primary care. They potentially also need to be seeing their, cardiologist, nephrologist, et cetera. We all really need to be working together to manage this as a whole picture, not just as a swollen toe.
Absolutely. My young 36, I think he's in his the mouth of a 36-year-old that's over 300 pounds and, crystals coming out of his spine. Certainly that's a project. That's a lot of education, a lot of coordinating for everyone to be communicating together in different multidisciplines.
So I have one last question for you. So as we wrap up, what are the key clinical clues that should prompt providers to recognize a patient that may be progressing from symptomatic gout to uncontrolled gout? And what actions can they take to prevent long-term systemic complications?
Yes. Again, definitely, the visits, following, their blood counts, their kidney function, their blood pressure, maybe throw in a hemoglobin A1C with those patients, talking about uh, different comorbidities as well. We now see here, especially from today's education, that gout clusters itself in with metabolic and cardiovascular disease as well, that hypertension, the diabetes, chronic kidney disease. We also, I feel, in all our disciplines and in gout as well, we need to be thinking about that treat to target as well. We do a good job of that in rheumatology. Um, you were taught uric acid levels under 6. Well, how about thinking 3 to 4? That's something where I found many of these gout patients need to be. Don't be happy with just 6. So, what are you going to do with your xanthine oxidase inhibitors? Are you, titrate them? Think about things that we can do with the tools that we have for our patients, taking in consideration of their renal functions, blood pressure, cardiovascular disease and comorbidities. And then what about those refractory cases? That's something we definitely have not mentioned. And those are the tough cases in clinic. And you've got to watch out for those cases. You want to be, targeting, I feel, much lower than 6 for uric acid level. If you've got those refractory cases, then be thinking of the, biologic peglotilase or something like that for the patient. Again, taking in consideration comorbidities. Bottom line, I think also just remembering the immune system and how it's actually having a big part here for our chronic autoinflammatory disease state.
I love that maybe 6 is not good enough. I mean, I know there's been several patients I've seen that have a uric acid of 5.5, but still have a ton of tophi. And so, you really should be thinking about it even lower to finally get those tophi to resolve.
Absolutely.
Well, Wendy, thank you so much for joining us today and sharing your insight on this important topic. Gout is often viewed through the lens of acute flares and joint pain, but like we've discussed, uncontrolled gout can have far-reaching consequences. So recognizing the systemic nature of this disease is, I think, an important step towards improving the outcomes of our patients. To our listeners, thank you for spending part of your day with us. We hope today's discussion provided practical insights that you can take back to your clinic and apply in your everyday practice. As always, be sure to visit Content Rheum on RhAPP.org, where you will find a growing library of educational resources, podcasts, clinical updates, and enduring content designed specifically for rheumatology providers. You can also access RhAPP education on the go at the RhAPP ACE 2.0 mobile app, making it easy to stay connected wherever your practice takes you. Thank you again for listening to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. Until next time, take care.